hematology, oncology, pharmacology, warfarin. All right, so warfarin is mechanism of action is really, really important to understand. They love to ask questions on it. So make sure you understand it in its entirety, and hopefully this video can help. But once again, I'm going to point you towards those sketchy videos because they're going to be a lot more helpful than me just explaining it. So for warfarin, the mechanism of action is that it inhibits vitamin K epoxide reductase, okay? And what we know about vitamin K epoxide reductase, let's take a step back and talk about the pathophysiology first. We need vitamin K to be activated via epoxide reductase in the liver. Once vitamin K is activated with this enzyme, then it can go and gamma carboxylate our factors 2, 7, 9, 10, protein C and S, okay? So now we're blocking that ability. We're blocking epoxide reductase's ability, that enzyme's ability to activate vitamin K by giving the patient warfarin. This leads to then the inability for factors 2, 7, 9, 10, protein C and S to get gamma carboxylation, which hinders them, not useful. Okay, so it inhibits them. It inhibits the vitamin K factors. All right. Now, once again, they love to ask the question, what do we monitor? We have to monitor PT. Okay, so monitoring PT-INR is very, very important when providing a patient with warfarin, and they love to ask that type of question, okay, because it has its effect on the extrinsic pathway. All right. Now, what we need to know, first off, is just like clinical usage. Once again, this is a blood thinner, okay? So it can be used for multiple things in order to help us thin our blood, but it cannot be used in pregnant patients, okay? So because warfarin crosses the placenta, unlike heparin does, okay? So this is why we cannot use it in pregnancy, whereas heparin is safe to use in pregnancy, okay? Now, for adverse effects, once again, anytime I'm thinning my blood, bleeding is the number one adverse effect. They never will ask you about that, but I mean, they might. But that's just the first thing that you have to understand. Now, number two, and one of the main questions that they love to ask about heparin or about warfarin is our initial risk of hypercoagulation. And we already discussed this earlier on, but this is known as warfarin skin necrosis. And now what happens is that when I provide a patient warfarin, our protein C and S have the shortest half-life. Okay, so protein C specifically has the shortest half-life. So when I knock out our factors 2, 7, 9, 10, protein C and S, protein C is the first one to be gone in our blood. Okay, so out of our system first is protein C, which isn't good because that inhibits our overall, coagulation cascade. So if I drop protein C first, I still have other factors working in the blood because warfarin hasn't really fully cleared all the other factors. Then we have a possibility of an initial risk of hypercoagulation, which can lead to warfarin skin necrosis, okay? And this is an increased risk for patients that have an initial deficiency in protein C and S, right? It just makes logical sense. And we already talked about that for protein C and S deficiency, but remember, keep that in mind. Since protein C has the shortest half-life, okay, then we know that since it's a part of inhibiting the coagulation cascade, that means that if it's gone out of the body first, we have an initial risk of having hypercoagulation. And then that can lead to the warfarin skin necrosis. And that is emboldened by the fact that patients could potentially have protein C deficiency. So it makes your risk even worse, increases your risk for hypercoagulation. So how do you treat this? You just give them heparin as well. So when starting off with warfarin, give them heparin as well. They call that heparin bridging. And so that way that we can mitigate that risk of causing warfarin skin necrosis. Okay. Now, what they love to ask about is reversal of warfarin, okay? So we can give them vitamin K, right? Because we understand the mechanism of action is that we're inhibiting vitamin K epoxide reductase. So we can just provide them with vitamin K, and more vitamin K will get rid of the warfarin in the body, competitively inhibit, and then we can actually get vitamin K to work. The epoxide reductase can start to work on vitamin K again, and then activate those factors 2, 7, 9, 10, and protein C and S again, okay? But that whole process takes a while, right? You just heard me talk through it all. So vitamin K is going to have to go to the liver. It's going to have to outcompete warfarin so that epoxide reductase can work up on vitamin K again. And then once vitamin K works again, it has to gamma carboxylate our factors 2, 7, 9, and 10. So the liver is going to have to produce those factors again. And then it's a whole entire process that entails so much protein production. So if you need a longer reversal, give them vitamin K. But if you need rapid reversal right now, the patient's bleeding severely, we need to reverse the effects of warfarin immediately, also known as Coumadin. We are going to give the patient fresh frozen plasma. Okay, so fresh frozen plasma is just going to be providing the patient with factors from another patient. Okay, so the plasma contains all of those coagulation factors. So we're just going to immediately give them that bolus of fresh frozen plasma, and it's going to be really helpful. Okay, for providing a rapid reversal of warfarin. So for rapid reversal, give them fresh frozen plasma. For, just any type of reversal, not too long, you could give them vitamin K. Now, just key differences between heparin and warfarin. Route of administration, heparin is IV, warfarin is oral, okay? Site of action for heparin is blood. Site of action for warfarin is the liver, where the epoxide reductase lies, right? The onset of action of heparin is rapid, it's seconds. The onset of action of warfarin is slower, right? Because once again, we have to inhibit epoxide reductase, and then we have to wait for 2, 7, 9, 10 and protein CNS to finally dwindle down, okay? So that's important. The duration of action for heparin is hours. Warfarin is days. Monitoring, once again, very important. You monitor heparin with PTT, and we monitor warfarin with PT-INR. And then lastly, can it cross the placenta? Is it safe to be used? Heparin does not cross the placenta, so it is safe to be used in pregnancy, whereas warfarin is opposite. It is teratogenic because it can cross the placenta. All right, so keep those things in mind. Once again, your best friend's going to be sketchy for this. Put it in, understand everything that they're talking about, and they're going to be giving you all the answers, and hopefully it will be really helpful compared to what I just provided.